Byro, meeting is live, you can start.
আৰু 1 মিনিট আছে নেকি?
Already it is live in the YouTube, Byro, you can go ahead.
Okay. So, my dear colleagues and guests from rest of the country who are with us today, good evening to you all. At the outset, I thank you all for joining us in today's NEBOI classroom. And thanks for being with us in our earlier sessions too. Myself and the executive committee had to take a decision to reach our postgraduate students and our young surgeons who had no access to physical teaching during this current pandemic. I appreciate the scientific committee for coming up with nice topics that are of interest to all of us, particularly the young surgeons. Continuing on our aim to covering basic to advanced subjects, where Dr. Niteshwar had covered the basics of chronic otitis media in the earlier classroom. Dr. Kaveri Kakuti, who was my postgraduate student and has shaped up into a mature head and neck surgeons, would be speaking today on the topic of lateral skull base malignancies. Of course, she is daughter of our beloved teacher, neurosurgeon, late Professor Bhavesh Kakuti. The session shall be moderated by Dr. Bubul Roy, who passed MS ENT from All India Institute of Medical Science, New Delhi, in the year 2000. He did a 1-year senior residency in ENT and head and neck surgery from PGI Chandigarh in 2001. He has completed 3 years senior residency in ENT and head and neck surgery from All India Institute of Medical Science, New Delhi in 2004. Currently, he is working as a consultant in the Department of ENT and Head and Neck Surgery, Oncology Department in Health City Hospital and Excel Care Hospitals, both in Guwahati. Now I hand over the session to our invited moderator, Dr. Bubul Roy. Thank you, Bubul Roy, for accepting our at the 11th hour. And thanks for your commitment to NEBOI. Thank you. Dr. Bubul Roy, please.
Thank you, ma'am. Thank you, Navoy, for giving me this opportunity. Really, Andana Vaido talked to me and I had to accept it in the last minute. Thank you for giving me this opportunity to moderate the Navoy classroom. And I am excited to learn the subject here because private we is infrequently manage these cases. So I welcome all, and I also welcome Dr. Prathamesh Pai, who accepted our request to be here, and he will also enlighten us with his valuable comments. Lateral skull base is a difficult subject, and describing this in a simple way is challenging for the speakers. The complexity of the anatomy, the need for lengthy surgical training, and large number of efforts described over the years have made this subject even more difficult. Over the past few years, our understanding about the subject has improved due to the imaging technology. Chemotherapy and image-guided radiation therapy have also contributed towards this positive outcome. But in surgery, optimal disease clearance with minimal morbidity and mortality still remains a challenge. To enlighten us on this subject, we have with us Kaveri as the speaker, and also Dr. Prathamesh Pai, HOD Skull Base Unit, TMH Mumbai. And also I have requested Dr. Alok and Dr. appeal to join. If they find time, they might join. So, and I think everyone will be benefited from their valuable comments. Welcome, Ramesh sir. And Dr. Kabi, she passed her MA GNT in 2004 from DNC, completed her 2 years PG fellowship in head and neck oncology from Bibura Cancer Institute in 2016. Then she completed 1 year fellowship in skull base from TMS Mumbai in 2017 under the mentorship of Dr. Prathamesh Pai. Presently working as assistant professor head and neck oncology in BBCI Guwahati. And now I request Dr. Kaveri to give her deliberation.
Thank you, sir. At the outset, I would like to thank the organizing team and the executive committee of the NABOI for giving me this opportunity to share my experience and knowledge on the lateral skull base tumors in this esteemed platform. If I may be allowed, I'm sharing my screen for the presentation. I hope my screen is visible to everyone.
Yes, very much visible.
So starting my presentation today, first I will just give a short overview on the skull base as a whole so that we can understand the lateral skull base properly. Skull base tumors are a rare group of disease which remains in close proximity to the vital structures, various vital structures. So this route of spread are determined by the complex anatomy of the craniomaxillofacial compartment. And the skull base surgery, therefore, is a highly specialized set of surgical procedures performed to treat various conditions which affect the skull base. The skull base anatomy is a complex region and poses a surgical challenge. The skull base forms the floor of the cranial cavity and separates the brain from the other facial structures. 5 bones that make up the skull base primarily are ethmoids, sphenoids, occipital bone, paired frontal, and the paired temporal bones. For the purpose of ease and better understanding, the skull base has been divided into 3 regions: the anterior, middle, and the posterior. This is the division into anterior skull base, middle, and the posterior skull base. The anterior skull base is bounded anteriorly by the frontal bone, posterior wall of the frontal sinus, and posteriorly it has been bounded by the clinoid process, which forms the roof of the optic canal. The lateral part is formed by the frontal bone, and the ethmoids form the central part of the anterior skull base, which contains the cribriform plate through which the olfactory tract passes. This is the middle skull base. This is bound anteriorly by the greater wing of sphenoid and posteriorly by the anterior part of the clivus. Laterally, it is formed by the sphenoid bone, and posteriorly, it is also bounded by the petrous temporal bone. The important foraminas in the skull base are the foramen rotundum, foramen ovale, carotid canal, etc. The posterior skull base is bounded anteriorly by the basi-occiput and the basi-sphenoid and the petrous temporal bone, and a majority of the posterior skull base are formed by the occipital bone. Coming to the lateral skull base proper, these are rare tumors and primary malignancies of lateral skull base, including the tumors of the temporal bone, account for just 0.2% of all the head and neck cancers. It's a complex anatomical region in which a variety of pathological entities can be encountered. These can be congenital lesions, inflammatory lesions, vascular malformations, or benign and malignant tumors. Lateral skull base tumor management is a young discipline which has seen tremendous evolution in the last 20 years. However, it is still technically challenging, and hence a working knowledge of the normal as well as the variant anatomy of this region is important for effective management of tumors or lesions in this area. Lateral skull base also comprises of the following bones: that is the temporal bone, sphenoid, occipital bone, styloid process, and the zygomatic arch. For the purpose of better understanding and evaluation, the Irish and his group in 1994 has divided the skull base into three regions again, that is region 1, 2, and 3, after reviewing the pattern of skull base malignancies depending on the anatomical perspective and the pattern of tumor spread. According to this division, the region 1 comprises the anterior skull base and also the region between the clivus and the foramen. Region 2 includes the pterygopalatine and the infratemporal fossa, and with possible extension of the tumor to the middle cranial fossa. Region 3 incorporates the temporal bone with possible extension of the tumor into the posterior as well as the middle cranial fossa. In this division by Irish, the region 2 and region 3 comprises the lateral skull base. So the region 2 of that lateral skull base, it extends from the posterior wall of the orbit to the petrous temporal bone. It's formed by the infratemporal and the pterygopalatine fossa and the overlying part of the middle cranial fossa. And the important structures in this region is the internal carotid artery, the facial nerve, the eighth nerve, and the maxillary and the mandibular division of the trigeminal nerve. Region 3 is located mainly in the posterior cranial fossa and includes the posterior segment of the middle cranial fossa. The vital structures in this region are the internal jugular vein and the sigmoid sinus, and the lower cranial nerves, that is the 9, 10, 11, 12 nerves. This is the pictorial diagram of the lateral skull base. The various structures which are related to lateral skull base are the pinna and the ear canal, the middle ear, the inner ear, the vestibulocochlear nerve bundles, the labyrinth, facial nerve, internal carotid artery, the lateral and the sigmoid sinus, petrosal sinus, CP angle, the related neurovascular bundles, the middle fossa, the temporomandibular joint, etc. It is also closely related to various critical structures like the cerebellum, the cavernous sinus, sphenoid sinus, and various cranial nerves, naming the fifth nerve, the seventh nerve, the eighth nerve, and the lower cranial nerves. This is the radiological diagram of the lateral skull base, of the structures involved in lateral skull base. Coming to the pathology, the site of origin of tumors in the lateral skull base can be from extracranial structures, that is the skin and the soft tissue, the connective tissue. It can come from the skull base bones and the cartilage, or it can arise from intracranial structures like the meninges, the blood vessels, or the cranial nerves. The tumors can be either benign, commonly the glomus, the meningiomas, or the schwannomas, or it can be malignant tumors arising from the temporal bone, the infratemporal fossa, the parotid gland, or the scalp tumors. In short, about the temporal bone malignancies. The temporal bone malignancies are rare tumors with a prevalence reported at 1 per million. The ear canal and the temporal bone have various structures like the skin, the cartilage, the bones, the nerves, the vessels, the sebaceous glands, etc., which can give rise to tumors in this area. The structures in the vicinity, like the temporomandibular joint, the parotid gland, the meninges, can encroach on the temporal bone, and the vice versa can also happen. That is, tumors of the temporal bone can involve these vicinity structures. The mean age group to be affected are usually between 5th to 7th decade. The etiology of temporal bone malignancies still remain an enigma. Some reports have suggested chronic otitis media to be one of the causative factor. Some reports even suggest an incidence of around 50 to 70% of CSOM seen in temporal bone malignancies. Although the evidence related to this is not very robust, but maybe due to chronic infection or the chronic irritation due to this infection, they can have a carcinogenic potential. The exposure to radiation is also reported to have a causative factor in temporal bone malignancies due to exposure to radiation or radiation due to various tumors like the nasopharyngeal cancers or the lymphomas or the scalp tumors. And it has been found that the latency period between the exposure to radiation and the tumor manifestation can range between 5 to even 30 years. The squamous cell carcinoma has been found to be the most common histology, However, other histologies can also be encountered, like the melanomas, the basal cell carcinomas, adenoid cystic carcinomas, adnexal cell carcinomas, etc. The route of spread of temporal bone malignancies is that it can spread to in and around areas by various routes. Anteriorly, it can spread to the temporomandibular joint, the glenoid fossa, the ITF or the parotid via the fissures of Santorini and the foramen of Ashki. Inferiorly, it can spread to the stylomastoid foramen and can involve the facial nerve, or to the jugular foramen and can involve the lower cranial nerves. Medially, it can invade the tympanic membrane to involve the middle ear and the inner ear. Superior spread can cause erosion of the tegmen tympani and can cause extension to the middle cranial fossa. And posteriorly, it can spread through the mastoid air cells to the posterior fossa. This is a pictorial diagram of the routes of spread of the temporal bone malignancies. The nodal metastasis of temporal bone malignancies at presentation is reported to be less than 10%. The first echelon nodes of temporal bone tumors are found to be the intraparotid nodes, and from there on, they can spread to the cervical nodes. As in all head and neck cancers, nodal involvement is considered to be a bad prognostic factor. Distant spread at presentation is also rare, and it can spread to the lung, bone, or liver. There is no standard UICC or AJCC staging system for temporal bone tumors. So we use the modified Pittsburgh staging system to stage or to define the T staging of the temporal bone malignancies. The T1 tumors include tumors which is limited to the ear canal without bony erosion or without any evidence of soft tissue involvement. T2 are the tumors with limited external canal bone erosion and with limited soft tissue involvement. T3 includes the tumors with full thickness bone erosion of the ear canal and also the tumors which involve the middle ear and the mastoid. T4 includes all the rest of the structures involved by the malignancy apart from the ear canal and the middle ear mastoid. That is tumors eroding the cochlea, the petrous apex, the medial wall of the middle ear, the carotid, the dura, or the evidence of facial nerve palsy. The N and the M staging is similar to the UICC staging system. Clinical features of the lateral skull base tumors. The late presentation in a lateral skull base lesion is not a very uncommon feature. Most of them present with very vague symptoms, and so a high index of suspicion is important to detect these tumors. They can present with ear canal mass, ear discharge, hearing loss, facial numbness, facial palsy, or a vague fullness in and around the zygoma, temporal area, preauricular swelling, or localized pain and trismus if there is involvement of the ITF. And if there is intracranial involvement, there can be ataxia, there can be headache, or if there is nerve involvement, lower cranial nerves, then there might be change of voice or difficulty in swallowing. So how to evaluate a lateral skull base tumor? History is very important, which can give us an idea about the site of origin, depending on the predominant symptom, and these structures involved. A physical evaluation, a thorough physical evaluation is very important. An otoscopic examination, a thorough head and neck evaluation, audiometric evaluation, vestibular evaluation, speech and swallowing assessment, neurological assessment, as well as a vascular evaluation if in case a carotid artery or a sigmoid sinus resection is considered preoperatively. The imaging, usually we do a CT scan to know about the bony details and an MRI to know about the soft tissue delineation. Usually both these images are complementary and both are needed so that we get an overall idea about the extent of the tumor. A PET CT scan is usually done to know about the metastatic workup in case of an advanced tumor or in case of an aggressive histology. This is the radiological imaging, erosion of the skull base bones, facial nerve schwannoma, or the CP angle tumors. The histological examination, the biopsy is very important as in all oncological cases. The site of cancer can be a skin cancer. Usually the basal cell carcinoma or the squamous cell carcinoma, the melanomas are seen as the common biopsy reports. Advanced parotid tumors can have high-grade salivary gland histologies. ITF tumors can have sarcomas. Temporal bone tumors usually have squamous cell carcinoma as the histopathological report in almost 80% of the cases. To plan any treatment of lateral skull base, the performance status, that is the general condition of the patient, and the extent of the disease, that is the site, size, and the extension of the disease, is very important to plan any treatment protocol. If we plan a curative intent treatment for the lesions, then a preoperative or a pre-chemoradiation workup is very necessary. Also, we need to refer the patients pre-treatment to an audiologist, to a speech and a swallowing therapist, and a nutritionist for the overall evaluation. In case if you plan a palliative intent treatment, it will again depend on the general condition of the patient. If the patient is having a poor general condition, then just a counseling and a symptomatic care will be the standard of care. And if it is an advanced unresectable disease, but however the patient is having a good general condition, then we can consider a palliative radiation or a palliative chemoradiation in this case. All said and done, skull base tumor management is always a team approach, and representatives from various disciplines of medicine, including the head and neck surgeons, the neurosurgeons, the radiation oncologists, the plastic surgeons, the pathologists, rehabilitation specialists, speech pathologists, everyone is equally important. So coming to the treatment, as an all-oncological treatment, there are three main treatment modalities: surgery, radiotherapy, and chemotherapy. The goal of surgery is to remove the disease, to achieve negative margins, and to minimize the morbidity as well as the mortality. The surgical decision depends on the characteristics of the lesion, that is the site and the size of the tumor, the histology. For example, if a histology is a chemosensitive one, that is a sarcoma, then the patient will go for chemotherapy rather than surgery, even if the tumor is resectable. So histology plays a very important role in the surgical decision. The exposure, the excess needed, and the degree of morbidity which can be accepted to achieve this goal. All this will plan our surgical decisions. A proper incision planning and an adequate surgical approach can go a long way in reducing the post-operative morbidity. A well-placed surgical incision will give a good skin flap without endangering its vascularity, and an adequate surgical approach will give a good access to the lesion. Sorry. The first incision that can be via which the skull base tumors can be approached is a preauricular incision. And from this incision, we can approach the ITF, the zygoma, the parotid gland, and also the neck and the middle cranial fossa with an upward and a downward extension. Next is the postauricular C incision. This is considered to be the workhorse of the skull base incisions, of the lateral skull base incisions. And various surgical procedures can be approached via this incision. Temporal bone resections, the transcochlear approaches, translabyrinthine approaches, subtemporal approaches, all can be approached via this incision. In earlier times, if a resection includes both the clearance of the mastoid and the resection of the parotid, then it was seen that a Y incision was given in order to access the mastoid as well as the parotid. However, in this kind of an incision, it was seen that the vascularity of the pinna gets endangered, because as we know, the vascular supply of the pinna is from the superficial temporolateral system and the posterior auricular system. So if you give both the incision arms, then this pinna necrosis becomes a higher probability. So the postauricular incision can give a good surgical access without endangering the pinna necrosis, and it can be achieved by anterior retraction of the pinna after freeing it off from the ear canal. And this can also give a very good access. For example, this is a standard post-auricular C incision. Via this incision, after freeing it off from the ear canal, you can very easily approach or access the parotid, the ITF, as well as the zygoma if needed. So the Y incision may not be necessary in all the cases, and post-auricular C incision gives a very good surgical access without endangering the pinna. The next is a cozy approach, that is the cranio-orbitozygomatic approach. Here the incision starts from just in front of the tragus and then goes up into the midline behind the hairline. Via this approach, we can access the supraorbital rim, the zygoma. Apart from the ITF, it also gives a direct access to the middle cranial fossa and the temporal bone and minimizes the brain mobilization. The next is the fish ITF approaches. As described by Hugo Fish, this approach can give a good access to the ITF, the petrous apex, the clivus, and the extensive tumors of the temporal bone. In this technique, it includes the permanent anterior transposition of the facial nerve, the resection of the mandibular condyle, and the mobilization of the zygoma and the lateral orbital rim. The next, this fish ITF approach can be accessed via a preauricular incision or a post-auricular incision, depending upon the structures to be accessed and the area of exposure needed. The next is the facial translocation approach. This was originally described by Ivo Jenica, but it has undergone tremendous evolution after that. It gives good versatility and a wider exposure at the skull base because of its modular design. Also, because of the modular designs, the facial subunits can be repositioned, and hence it gives a good aesthetic as well as a functional outcome. There are various facial translocation modules like the mini approach, the standard approach, and the extended facial translocation approach. The posterior extended facial translocation module gives a very good access to the ear, the temporal bone, the ITF, and the posterior cranial fossa, and hence it can be used for the lateral skull base approach. Surgery for the temporal bone malignancies. The extent of resection will depend upon the stage and the extent of the disease.
Kabiri, you can take some water. We'll wait for you.
Yeah, it's okay, ma'am. I actually am waiting for someone to bring me a glass of water. It's okay. Conventionally, there are 3 temporal bone resection surgeries: the lateral temporal bone, the subtotal, and the total temporal bone resection. The lateral temporal bone resection is appropriate for T1 and T2 tumors. It includes resection of the ear canal, the tympanic membrane, the malleus, and the incus. The boundaries of resections are medially the middle ear cavity and the stapes, posteriorly the mastoid cavity, superiorly the epitympanium and the zygomatic root, anteriorly the temporomandibular joint capsule, and inferiorly the medial tympanic ring. The subtotal temporal bone resection is usually done when there is invasion medial to the tympanic membrane and is involved the middle ear and the mastoid. That is the T3 disease. The specimen includes a lateral temporal bone resection along with an additional dissection of the OT capsule and the medial bony wall of the middle ear and the mastoid. The boundaries of resection includes posteriorly the sigmoid sinus, superiorly the middle fossa dura, anteriorly the internal carotid artery, inferiorly the jugular bulb, and medially the petrous apex. Total temporal bone resection was originally designed to address the T4 disease. It includes a subtotal temporal bone resection with additional resection of the petrous apex. The sigmoid sinus, the jugular vein, the internal carotid artery, the dura can be removed as indicated by the extent of the tumor. It is associated with significant morbidity and may not always significantly improve survival in advanced cases. It's a very morbid surgery and may not be worth resecting. The next is this is the pictorial diagram of the temporal bone resection. This includes the lateral temporal bone, the subtotal temporal bone, and the total temporal bone. The standard treatment protocol in a temporal bone malignancy, the minimum surgery which is needed in any temporal bone malignancies is the lateral temporal bone resection. The T1 tumors usually suffices with surgery alone. In T2 tumors, surgery followed by adjuvant radiation is given. In T3 or T4 tumors, surgery along with a superficial parotidectomy and a level 2 sampling can be done. Obviously, this is in a case of clinically N0 neck, and this has to be followed by adjuvant radiation. Or in case of unresectable tumors, we can even go for definitive chemoradiation. However, T4 tumors, which are T4 by virtue of its anterior extension, like involvement of the parotid or the temporomandibular joint, they do well, and they can be surgically resectable. Rishi. Another matter of debate is the en bloc resection versus the piecemeal resection. The en bloc resection.
Kaveri,
yes, ma'am.
Kaveri, take few minutes, 1 minute break and take some water.
Yeah, ma'am. Yeah, I think so.
You off your video and just go and take the water.
Yeah. Yes, ma'am. Sorry for this interruption. The next, another matter of debate is the en bloc resection versus the piecemeal resection. As is the standard in any oncological procedures, en bloc resection is the acceptable rule. However, the en bloc resection of the subtotal temporal bone and the total temporal bone resection involves considerable morbidity and Piecemeal resection, by definition, removes the tumor bit by bit as if chasing the disease until normal tissue is encountered. That is why, due to the extensive morbidity and the technical challenge, the current trend is to be shifting towards piecemeal resection from en bloc resection. And there are various studies which have found significant or equal survival benefit between the en bloc resection and the piecemeal resection. Dean et al. Performed a modified, which he called as a modified subtotal temporal bone resection, which consisted of the lateral temporal bone resection and local excision of the involved portions of the temporal bone with aggressive skull-base drilling through the tumor-involved area until a negative margin is achieved. Hence, a piecemeal resection in case of extensive tumors can give almost equal survival as an en bloc resection without the associated morbidity. It's also equally important to know which tumors are treatable and which are not treatable. T1, T2, and T3 tumors are considered to be treatable, and among the T4 diseases, those with anterior extension, the preauricular soft tissue involvement, these are considered to be treatable. The non-treatable tumors are those with a significant posterior, medial, and the superior extension, the inner ear involvement, gross brain involvement as or a metastatic disease. The management of neck, the standard protocol is we do not perform a prophylactic neck dissection in a clinically N0, and we do a modified neck dissection in a clinically N plus neck. The rate of occult metastatic nodal rate has been found to be 15 to 17%. However, nodal metastasis is considered to be a poor prognostic indicator, with studies reporting disease-free survival falling from 62.5% in a node negative to 33% in a node positive neg. Role of radiotherapy is basically limited to the adjuvant settings. Even though T1 tumors suffices with a single modality treatment, that is either surgery or radiation, it is found that the 5 years overall survival is significantly better if we do surgery as compared to radiation alone. In some unresectable tumors, definitive chemoradiation has been tried, where they have found not a statistically significant 5 years overall survival, and they have concluded saying that in unresectable T4 diseases, a definitive chemoradiation can be tried as compared to a morbid surgery. There is no standard chemotherapy regimen till date for lateral skull-based histologies, except for chemosensitive tumors like sarcomas. There are some reports where they have used NACT, that is induction chemotherapy with TPF regimen, and have found 50% cases turning resectable. Some reports have also used concurrent chemoradiation with a triple regimen chemotherapy and have found a very satisfactory survival. However, these reports are very scarce, and it's not the standard of care till date. The prognostic indicators of lateral skull-based malignancies are the tumor histologies, the higher T stage, the neck nodal metastasis, the distant metastasis, and the margin status. The pre-op facial palsy is also a very important prognostic indicator, with the survival falling from almost 60%, 5 years overall survival falling from almost 60% in facial nerve intact tumor to almost 20% in a pre-operative facial nerve paralysis tumor. In short, I would like to just share our experience at our institute, that is Dr. B. Barua Cancer Institute. We have constituted the skull-based clinic and have been doing we have been seeing skull-based cases in our institute from October 2017. Overall skull-based cases we have seen are 110, but apart from among them, only 20 cases have been lateral skull-based with a higher female to male ratio. Almost 55% of the cases were squamous cell carcinomas, but other histologies were also found. Almost 65% cases were temporal bone malignancies, but we also saw some advanced parotid cancers involving the ITF and the scalp tumors. In this database, we have not included advanced oral cavity cancers with ITF involvement or with skull base involvement. These are only primary tumors involving the lateral skull base. We could give a curative intent treatment in 60% of the cases. Among the curative intent treatment, 66% cases underwent surgery. We gave definitive chemoradiation in unresectable tumors in 2 cases and induction chemotherapy in 1 case. However, the results were not very satisfactory. Chemotherapy alone was given in 1 case of sarcoma that we encountered. There are some case scenarios. These are some representative case scenarios that we see in lateral skull base. The first is a case of mucoepidermal carcinoma, parotid with ear canal involvement. This was the preoperative picture, the intraoperative resection picture, and the postoperative picture. The second is the squamous cell carcinoma, ear canal. That was a T2 disease. This is the tumor, as we can see. We gave a postauricular C incision, and we earmarked the ear canal tumor by taking an adequate margin. This was the intra-op picture, and this temporal bone, the operated cavity was filled up with fats, and this was the post-op picture after radiation. This is a case of adenoid cystic parotid recurrence with ITF involvement. It was an adenoid cystic, considered to be a good histology as compared to squamous cell carcinoma, but it was an extensive disease with the tumor involving the foramen ovale. However, even with such an extensive disease, the mouth opening was nice, and hence we thought that will be a good histology. It's a good histology, and the tumor will come out. And hence we went forward with surgery, and we could take out the tumor in totality. And this is the foramen ovale intraoperative, from which the tumor was removed totally. This is a case of basal cell carcinoma temporal scalp. This is the resection picture, and we reconstructed it with a free forearm flap. This is a squamous cell carcinoma temporal bone. Clinically, it seemed to be a very small stage tumor. This is the ear canal mass, and the patient did not even have a facial nerve palsy preoperatively. However, when we saw the scans, it was very extensive with extensive skull base erosion and intracranial involvement, and hence the patient was considered to be unresectable and went for palliative radiation. So to conclude this discussion, skull-base surgery necessitates learning unfamiliar surgical anatomy, because the potential for disaster is great if we do not know this, or if you're not familiar with this surgical anatomy. The treatment decision is dictated by the histology and the extent of the disease. As a surgeon, it is also equally important to know when not to operate in order to reduce the morbidity and the harassment to the patient. And all said and done, skull-base tumor management is very much a teamwork, and hence with a dedicated team working towards it, we hope to offer proper management to this group of rare tumors, so that this group of patients need not go outside our state for its management. Thank you.
Thank you, Kaveri. Now over to moderator, Dr. Bubul Roy. Dr. Bubul, please unmute yourself.
Thank you, Dr. Kaveri.
Thank you, sir.
It was a nice presentation. Now I would like to hear Alok Thakur sir few comments on the skull-base tumors, lateral skull-base tumors. And I also welcome Thakur sir.
So thank you, Babul. Am I audible? I hope.
Yes, sir.
You're audible, sir.
So that was a fantastic presentation. I very much enjoyed it. Thank you. Very good. So as was said, it's a tumor which nobody quite has extensive experience in, but yes, the cumulative experience over the years from multiple institutions is now gathering up. Histology, as you said in the last slide, is the most important predictor on how to move forward. Certainly, you feel more comfortable with low-grade tumors if you have one, which means the ceruminous adeno-CA or the adenoid cystics. Squamous cells are unfortunately more aggressive, but also more common. We published our data a few years ago. Ajit Gandhi, who was our radiotherapy colleague, published the data with 55 patients some 4-5 years ago. I think it was 2002 to 2012 when we had sort of reported 55 patients. And what stood out was that when we did surgery plus radiation, we did remarkably better than we did radiation alone. Of course, in 2002, we were still transitioning from the era when we used to do radiation as primary treatment in a lot of patients. And it was the routine administration of sectional imaging on CT and high resolution CT and MR, which I think changed the scenario in terms of knowing which ones are resectable and which ones were not resectable. So the only thing I would have a slight disagreement with Dr. Karita is with regard to the parotid. So we have come to realize that soft tissue extension is a major component of the tumor. And though, of course, the atlases and books tend to focus on the bony component because they have been done by otologists in general or skull-base surgeons in general, we focus a lot on the soft tissue component. So every Lateral temporal bone resection in our book also gets a superficial parotidectomy with soft tissue clearance. It gives you much better soft tissue clearance around the ear canal, and every subtotal temporal bone resection now gets a total parotidectomy. You're sectioning the facial nerve anyway, so that I think improves local control. I agree with you totally that a Y incision is something we have given up on. It did cause necrosis of the lobule and the pinna and didn't heal very well and delayed radiation. So we also tend to prefer the post-auricular incision now if feasible. Pre-auricular can be done, but post-auricular gives you better access um, to get the angle to work on. It gives you better access. The pre-auricular doesn't quite give you such good access in the posterior part of the middle cranial fossa where you really need to work. Beyond that, no, nothing more to add. Yes, T1 tumors are almost impossible to get. In our series of 55 patients, we had only two. T2 tumors and T3 tumors are usual. T4 tumors, as you said, don't generally go for curative treatment, so don't quite form a data set which you tend to follow up very much. I would leave it at that. Yeah, but I enjoyed the presentation. I think it's very comprehensive, and my congratulations. You did show some very difficult cases.
Thank you, sir.
Bubul, you unmute yourself. Bubul, you are mute.
Thank you, Dr. Sir. May I now request Professor Prathamesh Pai to give valuable comments, because Dr. Kaveri is
Thank you, Bobul, and thank you to Niboy for inviting me to be participate in this meeting. I think Kaveri did a fantastic job and has presented the entire gamut of treatment of the lateral skull-based tumors very elegantly and succinctly. What stands out is that we need to evaluate these cases very clearly and with a proper format. I saw one question regarding the MRI sequences. What is more important in temporal bone cancers, as it is a bony lesion, would be to do a CT scan upfront, and usually it's a high resolution CT scan. And we would like to differentiate a external canal from a middle ear involvement, because that will make a difference in your decision making and towards doing a more conservative surgery as far as the facial nerve is concerned. So she showed very elegantly how you can actually even save the facial nerve even when you have a T3 lesion and the lesion has got a middle ear involvement. So gone are the days where we would do very extensive subtotal temporal bone resections with very wide access, with a large craniotomy, and encounter issues of bleeding due to tears in the sigmoid sinus or the jugular bulb or the veins which are draining into it. Also, all the cases do not really require a temporal mandibular joint resection. So when we analyze our series, we found that amongst the 26 cases that were analyzed at that point, only one case actually involved the TM joint capsule. So that led us to be very conservative as far as resecting the TM joint. I agree with Alok that the parotid needs to be more examined in detail. And even in the T1, T2 lesions, if they are placed anteriorly, we would then recommend doing a parotidectomy, because then through the natural passages in the tragus, they would be, having a tumor access onto the lymph nodes in the preauricular region. So for a T3, T4 lesion, we would definitely do a parotidectomy and the level 2 clearance. And as Alok said rightly, you get a better clearance of the soft tissue in the vicinity of the temporal bone. So the incision that we now have honed down to is the posterior C-shaped incision. And that actually gives a very good access to the temporal bone, to the famous part of temporal bone, the trapezoid, as well as the neck. So you can do a comprehensive dissection, you can do a parotidectomy, a level 2 clearance, as well as a complete temporal bone resection. If required, we can even do a craniotomy and clear the disease and superiorly and anteriorly. So I again congratulate Kabedi for the very well done presentation, and I'm sure it was a very good learning experience for all of us. Thank you.
Thank you, Dr. Prathamesh. Thank you for your valuable inputs. May I now request Dr. Kapil to give some comments?
Hello, sir. Can you hear me?
Yeah.
So
Yes,
I think there is nothing more to be said. It was very nice presentation by Dr. Kaberi, and everything regarding our institute, Dr. Alok sir, he has already touched on a few points, and Prathamesh sir also. So I was just running through the comments and queries from what others they have to say about this. And regarding neck dissection, sir, I think neck can be addressed to the same incision. We reviewed our protocol, and for if it's a T1 or T2 disease, early disease, you need not do a neck dissection. But if it's more than that, then we can easily address level 2 and 3 lymph nodes through same incision, and we can sample them unless it's an N plus disease. So I think that is one addition to that. If it's early only T1 disease, you need not do a neck dissection. If it's anything T3, T4, then you can address level 2 and 3 through same incision what we have employed for the lateral temporal bone resection. I would also like one take-home message from this talk, which ma'am had mentioned, that lateral temporal bone resection is the only surgery recommended even for earlier stage disease. There used to be mention of sleeve resection initially, but that is no more a recommended surgery for any ear or temporal bone cancer. Am I still audible?
Yes,
yes.
yes.
Yeah. So and someone has also mentioned about subtotal petrosectomy. I think, sir, you would agree with me that there is literature in favor of even piecemeal resection for advanced stage temporal bone cancers. This is not a very elegant way to excise it, but results with a piecemeal excision as well as en bloc incision with subtotal temporal bone resection, they have been compared, and they are more or less comparable. So if you can remove the disease with a subtotal petrosectomy and a good clearance, even if it's piecemeal, then results are as good as a en bloc subtotal temporal bone resection. So overall, it was good experience, sir. We learned a lot, and thank you so much, Dr. Gubul, for making us a part of it.
Google, unmute yourself.
Thank you, Dr. Kapil. I think I have not introduced Dr. Kapil. He's a professor at All India Institute of Medical Sciences. So thank you for his. Thank you, Dr. Kapil, for your input. So
If there are any audience questions, we can take them. Otherwise, I guess we can.
yeah, that
You can see the chat box.
I don't see any questions right now.
Okay. Can I read it for on behalf
Anjana,
of
you read it. Yes.
Yeah.
Anjana, you read it.
Yeah, Dr. Akhil Sharma sir has asked, what is the philosophy in the surgical decision? Will you explain to the patient the high morbidity and take his consent for surgery as well?
Kaberi, this is for you.
So definitely, the counseling of the patient is of utmost importance, but we have to explain them that the morbidity is involved because they might not be knowing it. So that the standard treatment protocol that we follow, we'll explain to them that first, and then after explaining everything, then the decision will be telling them that usually we do not go for a en bloc resection, although it is an oncological procedure, but we do not go for it because of the morbidity. And I guess the patients usually listen to us and they accept whatever we say in this surgical decisions that we usually tell them about. That was the question? I did not get it properly.
Yeah, that's the question, of course. The in SHAMBU, it has been clearly mentioned that it is a surgeon patient, both will have to agree after the patient knows about the high morbidity in extensive cases, of course.
Yes, sir, that is true in all cases of, in all surgeries, not only in the malignancy or in skull base. All surgeries, it has to be a one-to-one communication and a dialogue between the patient and the doctor. The patient has to be explained about everything regarding the surgery or the treatment, and then maybe they can together take a decision on the treatment protocol. But yes, the morbidity part, they have to be explained because they don't know it. And we also have to counsel them that this is the best for you because this procedure is more morbid and may not even be helpful for you. So, but yes, the dialogue between the patient and the doctor is of the most importance.
Okay.
One more question. Any specific MRI sequences for skull-based malignancy? From Dr. Biswajit Gogoi.
Paisa has already said about it.
Yeah, right, yes. So one question is little details about the tympanic bone and jugular foramen workout.
If I may just add, Kaberi, that we need to specify that you should always do an MRI sequence with contrast. And at times we were also doing a venous angiogram because we were concerned wherever we were trying to resect the sigmoid sinus to look out for the dominant venous sinus. So you might consider doing a MRI with a contrast as well as a venogram, because that might be instrumental in decision making at times.
Yes.
One more question, role of endoscopy in lateral skull-based surgery. Kaveri.
Role of endoscopy, usually we do not do endoscopy procedures in lateral skull base. I do not have any experience. Paisa, have you?
This is today's DNB question. DNB paper today's paper.
Achha, okay.
Thank you.
I do not have experience.
So it is interesting to see that this was a DNB question. Makes me smile. But yes, a year or so ago in a journal club, one of our residents did present a series of 5 patients where acoustics had been removed through an endoscope through the ear canal. So it does seem it is feasible and possible, but no, not part of our usual practice. And of course, the tumors that had been removed by the endoscope through the ear canal would be otherwise so small that you would wonder if they needed surgery or needed treatment at all. But yes, it's been done. And there is the issue of microvascular decompression for neurovascular syndromes that occur in the 5th nerve and the 7th nerve, wherein through a posterior fossa craniotomy, you can put in an endoscope and put in a piece of Teflon between the vessel and the nerve for trigeminal neuralgia. I think that is what was being probably asked in the DNB question. But no, it's not part of what we do for malignancy.
There is a question by Dr. Biswajit Gogoi about routinely doing a CT angiography or a balloon occlusion test preoperatively. I think if it also depends on the histology. If it is a very aggressive histology like the squamous cell carcinoma, then involvement of the ICA makes it actually unresectable. We go for a CT angiography or a balloon occlusion test or a venogram if preoperatively we think about resecting these structures like the internal carotid artery or the sigmoid sinus. But if you do not think preoperatively that we will be doing anything with the structures, we usually do not go for a routine assessment of the structures. And again, the histology will play a role. Usually squamous cell carcinoma, such an aggressive histology, involvement of these structures makes it unresectable. In a good histology like an adenoid cystic, we might think about maybe handling the structures. Then we may need this angiography or a venography.
Kaveri, what about glomus tumors?
So glomus, yes, sir. Glomus, because we have to see the vascularity, and so in those tumors, we go for a balloon oxalation test or a carotid artery assessment preoperatively, because it involves the handling of the carotid there. That is a benign tumor. So in those tumors, we go. I mean, I was saying about the malignancy. So malignant cases, we usually do not go routinely for this.
Absolutely.
So will you operate cases with pterygopalatine fossa extension? Kaveri?
Yeah, pterygopalatine fossa. Again, histologies like squamous cell carcinomas, the involvement of these fissures usually makes it difficult to resect or not worthy to resect, because we will not get a margin at the fissures or the foraminas. But yes, in good histologies, we can go for a resection of the tumors, even if they involve these fissures or the foraminas.
Like an adenoid cystic malignancy.
Adenoid cystic, right.
How do you treat histiocytosis X?
It's not part of the routine cases we get, so I don't have much of an idea about it.
Would be a histiocytes, where usually these are treated with chemotherapeutic agents. So you would first want to see if this is a generalized histiocytosis, and if so, then you would want to evaluate it with a PET CT scan, and then consider giving chemotherapy.
How is the surgical improvement after doing surgery on histiocytosis X? Do you expect that the disease will be cured? Because it seems that it has got good prognosis.
So usually you would not want to resect this lesions, and you would want to consider for either a chemotherapeutic treatment or observation, because if it's a very localized disease, you may not even consider chemotherapy. So that really brings into the focus the point of evaluation of these lesions, whether they are localized or disseminated. If they're disseminated, then you would consider chemotherapy so that you would have a response evaluation. But as Kaveri said, we really do not come across this. I have come across only some forms of histiocytosis, not a histiocytosis X. I don't know about Alok.
So yeah, we see it now and then, especially in kids with the diffuse histiocytosis, literacy disease. As you said, we treat it by chemotherapy. If it's a localized histiocytosis X, I haven't seen it for a while. If I do see it, I think I'll have to go back and just check on the literature again as to what is recommended nowadays.
That's true.
But diffuse one we treat with chemo, which basically means steroids. They use steroids to a large extent. And
yes,
these patients reasonably.
Also, yeah.
These patients do the diffuse one you can't quite excise. I mean, it's everywhere. It's in the skin also. So surgery is only for biopsy, and then from then on it's about chemotherapy, and it's a disease which responds well.
Yes, the disease is very rare, but yes, you know that sometimes the diseases come in a row, though they are very rare. When I was a house surgeon in PGI, Chandigarh, we saw 3 cases coming in a row. In fact, all the 3 patients were admitted same time in the ward. And no surgery was done. Yeah, no surgery was done. It was the chemo radiation was also given.
Dr. Harindra Narayana is there. Sir, can you unmute yourself? Yes, something to share. Harindra Narayana.
Yeah. Thank you so much. Good evening to all of you. It was an excellent presentation. I just wanted to say that in a lateral T1 there was a comment saying that sleeve resection has no role at all. Now, if there is a very isolated lateral lesion, maybe we can still get away with a sleeve resection and maintain and preserve the tympanic membrane by doing something like a intact bridge mastectomy, taking away the external auditory canal in total by drilling out the tympanic membrane for tympanic bone and thinning it out till the periosteum, for example.
I see your point, Dr. Harindra. I mean, if you have something on the concha, which is a low-grade issue like a ceruminous adenoma or something, then I suppose you could do something of that sort. Yes.
Yeah, you cannot just right away sleeve resection at all, even for an early
I
squamous
think
cell
what she meant
carcinoma.
was that if there's a tumor of the external auditory canal, then especially if the bony external auditory canal, then certainly that would be inappropriate. But yeah, I mean, there would be the
My
odd
point
situation.
was, even squamous cell carcinoma of the external auditory canal, a T1 has got almost an 80% survival rate for a 5-year survival rate, even for a sleeve resection, what was practiced earlier also. That's got almost 80%. But the survival hasn't increased, it will not increase substantially by doing a lateral temporal bone, even for a T1 squamous cell carcinoma. That was my limited point. But I agree, we have to be careful with the margins.
So I quite agree, but I mean, even if you do a lateral temporal bone, ultimately you can still do a type 3 kind of tympanoplasty if you really thought. So,
yeah.
So I mean, of course, the clinical acumen comes into it, and I agree with what you say that there would be the odd situation wherein maybe you can preserve the eardrum if it's very distant.
Yes.
Even if you take the eardrum, I mean, you can still reconstruct hearing.
Correct. I agree.
We have done that now and then. It's a pleasure to catch up with you.
A rare drop in from somewhere. Thank you so much.
Also, I would like to add that if you have lesions,
pardon me, there's some disturbance.
Which are, I think there's a lot of disturbance. If you have lesions which are skin cancers, and as Alok was referring to those may be more suitable for a sleeve resection rather than a squamous cancer coming from the middle ear or the external canal. So maybe, like you said rightly, evaluate the tympanic membrane, see how close it is to the tympanic membrane, and then make a decision whether the patient will benefit from a sleeve resection. Now, the problems that we encountered in the few cases that we did was that the meatus tends to stenose, and then you have an issue with keeping that wide with a stent in place, and those are the cases that have a cosmetic outcome which is even worse off than a lateral temporal bone resection. So you need to actually weigh your options and look at what's going to be an extent of resection and then plan the surgery.
If I can just make one more small point, which was not probably highlighted a little bit, can I?
Yes, sir.
Yeah, it's the same thing. We have to differentiate between the lesions which are lateral to the temporal bone, the tympanic membrane, versus the lesions that are medial to the tympanic membrane. The lymphatic drainage, the behavior is very different. So if we have a lesion which is lateral to the tympanic membrane, we have to concentrate on the parotid in the neck. But once it goes into the middle ear, I think the prognosis and everything drops because the lymphatics will go along the eustachian tube deep inside. And I think that is where we lose the battle. The more experienced people can probably agree or disagree with me.
Bubul, unmute yourself.
Sorry, I was disconnected for a long time. So
there's also one question which has come from Ashok Das, which is about the incidence of ORN. Now, I don't know about Kaberi, but some of the cases that we have seen wherein the patients have undergone a radical mastoidectomy, And then the final report comes across as those granulations having squamous cancer. And those patients have been then sent for radiation therapy. We have seen a couple of them come back to us with osteoradionecrosis and a discharging cavity after a couple of months, which may not really fit into picture of ORN, but these are the cases that actually go on to have ORN. So what we need to realize is that if you do a radical surgery, a radical mastoid surgery, and you're planning to do radiation, cover this cavity with a vascularized temporalis flap so that during radiation, it doesn't damage the bones, the cavity is sealed off, and there's a cul-de-sac closure of the external canal.
Dr. Ashok, if you are there, please unmute, and if you have anything to share, you can share.
Right. Good evening, ma'am. Good evening, sir. What you have said is a very good actual suggestion. We just encountered one patient like that, exactly what you have described. So, as because this is very little unusual, and we just like to know from the experienced people regarding the management, and it's very right what you have said. Thank you.
Khuduzamed sir, would you like to say something?
During my time, I think we have done very few and far between cases of temporal bone resection. Only probably a couple of lateral temporal bone resections. And another case, like Dr. Ashok Das mentioned, we had a radical mastectomy with a cavity problem, sent for radiation those days. So other than that, I think we've got very few, cases to really show for lateral skull base. I think now the situation has changed with better imaging and better assessment of cases. And since I've left Beberwa, I haven't been doing much of major skull base surgeries.
There were few questions on management of neck node in squamous cell carcinoma temporal bone. I think that has been discussed in the forum. So I don't see any questions. Kaveri, is there any questions?
No, ma'am, almost every question has been discussed already. I think so.
Okay, over to Dr. Bugul again. If you have any input, you can.
Google network কি হয়েছে জান পাইছো?
Okay, I think
Google network is hang. Hello.
Okay. So now can I hand over the proceeding to Dr. Gautam Khan for his final comments and vote of thanks. Gautam da, please unmute yourself.
Yeah. Thank you, Anjana. Thank you very much. Dr. Kaveri, it has been a very nice presentation and it's very compact and concise in the time provided to you. We have learned a lot actually from it. Google, last minute replacement and done well. And thank you so much for getting Dr. Alok Thakur, Dr. Prathamesh Pai, Dr. Kapil Sikka is there, and I see some other names, Dr. Narayan is there, and some other names, I don't know everybody, for participating in this web-based classroom of Northeast branch. I hope if this was a good idea of being the experts in the field, because this is not a surgery like mastoidectomy or medial surgery, which everybody does quite often. So we can have, everybody tends to have a lot of experience. And this is something which is, we have started, that's very nice. in BBCI. We are doing cases gradually, and definitely as you go along, you'll grow in your expertise, and probably you'll have more cases in when you present next time, and it will be even more fun to have a good interaction with everybody. Thank you very much.
Thank you, sir.
Thank you, Gautam.
Yeah, I have a request to all. Kindly put on the camera before leaving, so that we can have a click.
Vishwajit,
camera on kori lok sobe.
Yeah. So thank you very much. And we had a nice evening and a very excellent presentation. Thank you all for attending this webinar. Thank you so much.
Thank you.
so we can conclude.
Thank you, Kaveri. Excellent presentation.
Thank you, Dada. Thank you.
Kaveri, thank you.
Well done,
Thank you,
Kaveri.
Dada. Thank you. Thank you.
Pani glass logo loi lobo laga age.
So Hari Bhaido,
Very good, Kabiri. Very good.
Fozia Bhaido, please, we are still live. Bhaido, YouTube live to off karo.
YouTube live off.